Well, thank you everyone for coming. What we're going to be doing today, and for all the people that are here live, all the people that are going to listen afterwards to the recorded session, we're going to be talking about long COVID. But this is going to be an evidence-based discussion. So, there's a lot of sort of ideas, thoughts out there, and we're going to go through it and hopefully focus on what do we actually know. So, as mentioned, I have done some advising for Pfizer. And here are the objectives. These were sort of flashed up, but let's just sort of the hope is you come out of this with three things. So one is, and I think this is important. I'm hoping that people at the end of this, and I'm going to put a lot of effort in this, are confident diagnosing long COVID because this can really make a difference. People are having issues, and as a starting point, it helps to actually be able to say, "Listen, you've told me what's going on. I can confidently diagnose this as long COVID," and then sort of move on from there. Now, this ties sort of back in is obtaining the proper baseline history and testing for patients with long COVID, and we'll go through like what are the criteria, what might the patient tell you, what tests might actually help you not only making the diagnosis and not missing something else, but also in getting some of the information you're going to need to step in with some of the evidence-based therapies. And this is going to make up the bulk of it. Number three, we're not just going to tell people you've got long COVID and boy, I'm sorry about that. But I'm hoping people feel comfortable at the end of this with being able to use current evidence-based therapies to treat long COVID. We're going to talk a bit about the different types of long COVID, and then sort of which therapies might be the ones to be thinking about based upon which type, which phenotype of long COVID you get into. All right. So, all right. So the first thing, and I sort of a little bit of embarrassment for our profession, right? I mean, I was talking just as we were getting ready to start up about when did I start actually taking care of people with long COVID, with post-infectious sequelae, and it really was in April of 2020. And initially, it was a lot of colleagues, right? Physicians, nurses, other healthcare workers that had gotten sick, and they were not better 3 months later, not better 4 months later, 5 months, etc. Now, there was a lot of sort of dismissing of these people. That's what I'm a bit embarrassed about because you know what? Post-infectious sequelae, they're a thing, and we've known about this for a long time. And it wasn't just COVID. It was a phenomenon called long flu. Some people get the flu and then they have ongoing issues. There've been some sort of famous people in history that suffered through that. Clearly post-polio syndrome, which I came to appreciate when I was practicing in rural Colorado. It really was a period of time when there was a lot of polio cases in Colorado. And then decades later, you had these individuals, which I was taking care of, with post-polio syndrome. Um, Not seen as much maybe now, but maybe some of our older colleagues remember the post-diphtheria demyelinating neuropathy. Certainly, a number of individuals, and maybe actually people on this call may be familiar with the post-chikungunya disease, this post-chick inflammatory rheumatism, where it's 6 months, 7 months, 8 months after the acute disease, still with crippling joint pain and inflammation. Post-dengue fatigue syndrome, post-Ebola syndrome. I'm wearing my Ebola bow tie today. I don't know if anyone picked that out. Acute fever. A little bit controversial, a little difficult. The post-treatment Lyme disease syndrome, folks that got Lyme disease, they were treated, maybe they were retreated, still they continue to have issues. Even a post-Giardia syndrome. In Colorado, a lot of folks would end up getting Giardia. It's even in some of the ski towns. You go to Aspen and might end up getting Giardia, and then some folks continue to have issues. So post-infectious sequelae, they were a thing. So it shouldn't have been as surprising as it seemed to people that people would get COVID. And it wasn't just like, oh, in 2 weeks, you're either better or not. No, people can get post-infectious sequelae. And when we had something like SARS-CoV-2 infections and millions of people at the same time, we really saw this connection. So how do we define this? What is post-acute sequelae? What is long COVID? What are the definitions? And I think this matters just so we sort of know what we're talking about. So what was the history here? So the term long COVID is a patient-created term and broadly defined as signed symptoms and conditions that continue or develop after initial SARS-CoV-2 infection. So when the term long COVID was first coined, you didn't necessarily have the how long does this need to go on, what exactly is in here. It really was people who just basically did not get better. So long COVID, sort of acute COVID, maybe there's a medium COVID that we might mention, and then long COVID. Post COVID-19 conditions. Now I'm going to say is equivalent to this late term long COVID, but maybe not. But PASC is actually maybe going to be where we sort of expand our understanding here. So post-acute sequelae of SARS-CoV-2 or PASC. Now, this is a term that was introduced, sort of pushed to be used in the scientific and medical communities that maybe refers to a broader situation. So this is ongoing, relapsing, or new symptoms or other health effects occurring after the acute phase of SARS-CoV-2 infection. It's got its own ICD-10 code, U09.9. And you can actually code this along with COVID-19, which is the ICD-10 code U07.1. And why do I even mention those codes? It's because for our patients and even keeping track of the diagnosis, it's important that you actually make the diagnosis. You don't just say, this is vague, I'm going to diagnose you with depression or insomnia or whatever else it is. The other thing you might notice here, and maybe if you think about it, is there's a sense that long COVID is almost like a chronic fatigue-like manifestation. But the term PASC, post-acute sequelae of SARS-CoV-2, is broader. It's really all the sequelae. Maybe an individual goes on and has a stroke or a new diagnosis of diabetes. We'll talk more about this. So it's a broader umbrella term, and it covers people that also develop that overwhelming fatigue presentation. Okay, so hammer this home, right? PASC, think of this as that very broad term and refers to such things as pulmonary fibrosis, new onset diabetes, new diagnosis of CHF, congestive heart failure. Long COVID, in contrast, is a long-term process that lasts for longer than 30 or 90 days after acute COVID-19. So you get some of these other things maybe even sooner, right? You had COVID and then maybe you develop pulmonary fibrosis during the acute disease, but that's going to continue. So it's still going to be a post-acute sequelae. But this concept of long COVID, and people have talked to be 30 days, is 30 to 90 that medium COVID? Is it really past 90 that we're going to say this is long COVID? Not explained by different etiology. That's going to be critical because sometimes folks come in, they had COVID, but now they've got another diagnosis. They've got something that might even be unrelated. So it's important that what we're talking about is not explained by a different etiology. And as we'll talk a little bit here, certain characteristic symptoms and actually biochemical and physiological abnormalities might be found. They don't have to be. It's not required. But we'll talk about some of the characteristic things that may be found, some of the objective stuff, and also a little bit about why that matters. Okay. So remind everyone, I mean, we all went through this, but just sort of keep it sort of straight in how we think about this. There was that exposure period, the incubation period before the person tests positive. They've been exposed, and that period, that incubation period, actually shortened with different variants of SARS-CoV-2, and that actually presented a certain advantage to the virus, sort of in evolutionary terms, right? The quicker you go from one person to the other, the more people you can ultimately infect in a period of time, right? If it's 7 to 10 days from patient A to patient B versus 3 days and then 6 days and then 9 days, right? You can 2 cycles in that 9 days, where if you're just taking that long to go from one to the other, right? So there was a selective pressure that really shortened that incubation period. Then we see the viral phase, the first week. really important to think about this and maybe give us some understanding about why, trying to use antivirals in long COVID, once we get out, 90 days or so, why it just really hasn't given us what we were hoping it would give. So first week, this is that acute viral phase. We'll talk a little bit about what we may or may not do before you get exposed, during that viral phase, and then later on that might actually impact your risk of long COVID. But what we're really going to do is we're going to be talking about those folks that really make it past those 8 weeks, maybe even make it past the 12 weeks and are still having issues. So we've got incubation period, viral phase, the second week or the early inflammatory phase. And then we end up with medium and move into long COVID. Okay. So we'll start off with possible, and then we're going to dive a little deeper into these. So what might be driving long COVID? And I have to say, like right out of the gates, everyone's jumping in. Everyone had ideas, and so now we actually have more than ideas, but evidence. And we'll talk a little bit about this. So one, and I think across the board, and probably driving a lot of people, and evidence behind this is you get acute COVID, and it ends up resulting in ongoing immune activation and some sort of immune dysfunction. And it was sort of simpling that down. As a guy with a PhD in immunology, it's a little painful that we don't get like an entire day to just talk about that. But I think that's reasonable, right? We're clinicians here. We don't want to just talk about the immunology. We want to understand how this impacts our patient and how we can take care of them. The next, and this is a bit controversial, but let's just be honest about what we're talking about. There is some evidence as a possible mechanism that remnant SARS-CoV-2 RNA or remnant SARS-CoV-2 protein are still there, are still present, are still driving ongoing immune activation or dysfunction. The reason I say it's a little controversial is the idea that there's actually ongoing viral replication. I mean, we've been looking for years now, not just months, and still really nothing compelling out there that you're going to biopsy somewhere and find replication competent virus outside of someone with profound immune suppression. So as a general rule, we're not seeing a lot of evidence that it's necessarily ongoing viral replication, but that doesn't actually matter. It only matters in that maybe that's why our antivirals have not been particularly effective, but we are still detecting RNA, we're still detecting protein. Dysbiosis. We'll talk a little bit about therapies and trials that have really supported that dysbiosis in certain people is driving long COVID and things we might do to help folks out. Endothelial dysfunction and dysfunction of the clotting system, certainly present in a number of individuals and directly related to the pathology and issues they're having. I don't know why this bothers me more than the others, but neuroinflammation, blood-brain barrier dysfunction, really seeing, college professors who have trouble like signing a check, right? There's a lot of people out there with sort of really debilitating cognitive issues, moving right into neural dysfunctions. This isn't not just cognitive, but neural dysfunction, issues with the autonomic nervous system, particularly vagal nerve dysfunction. A lot of interest. And I feel like out at the Mayo, they're sort of the pioneers in focusing on some of the mitochondrial dysfunction. And then really straightforward, not controversial. And I used pulmonary fibrosis as an example. During the acute infection, you can have a heart attack. You can get scarring of the lungs. You can get all kinds of other issues. So you might just have residual damage from acute infection. So it's still a post-acute sequelae, but sort of residual from that. So let's talk a little bit about each one of these. And I will try to move a little quicker than I guess I really want to, because I want to make sure we spend most of our time talking about the therapies. Like the point of understanding these things is so we can actually help our patients. And I want to spend most of the time talking about that. But early on, we just sort of waved our hands. Immune activation, dysfunction, that seems to be going on. The immune system doesn't realize the acute infection is over and it keeps causing us problems. You feel sick because your body thinks you're still sick. And a lot of studies have shown that, yeah, there are objective issues in a lot of folks that have post-acute sequelae. So you might have exhausted SARS-CoV-2 specific CD8 positive T cells. There may be some miscoordination between your T cells and your B cell responses. There might be persistent complement dysregulation. There might be altered coagulation marked by increased soluble CD5b, C6 complexes. I apologize for talking about complement. I know we just lost half the audience there, but that's the last time we'll talk about it. It's okay. Elevated platelet markers, monocyte platelet aggregates. So really, this isn't just a theory. There's actually there's good evidence that this is involved for a lot of folks that continue to suffer. Now, what about this? Yeah, remnant SARS-CoV-2 RNA. This is actually a thing. And we've actually a number of studies where we've actually months later, 6 months later, really following these people long term, we're still able to detect viral RNA using in situ hybridization. And we're able to amplify it with PCR. So these are people months and months later, right? We were sort of taught like RNA, it lasts for a few hours, maybe a couple days. But here we are seeing the RNA months and months down the road. Protein, similar. We do biopsies. A number of the earliest studies were when they did biopsies of the small intestine, and you're still picking up SARS-CoV-2 spike protein in these biopsies months and months later. Okay, dysbiosis, and this is going to actually lead us to, some treatments when we get there, is during the acute phase of COVID, you actually get the depletion of certain microbes such as bifidobacterium, and you actually get an overgrowth of certain microbes such as the Bacteroides, Clostridial species, the Firmicutes. So yeah, so actually the acute COVID can disrupt our microbiome, and this can persist for periods of time afterwards. Okay, endothelial dysfunction of clotting system. Yeah, when we do studies and we look at platelet activation markers, we actually see that they're elevated. There's some studies where actually we're seeing monocyte platelet aggregates. Neuroinflammation, blood-brain barrier dysfunction. So you can get gliosis, you actually get activation of the microglia in the brain. You can get polyclonal B cell activation, again, exhausted T cells. Some studies have actually shown that if you follow people that have post-acute sequelae, particularly a subset of folks that are having or reporting cognitive issues, the brain fog that we're familiar with, you actually can see decreased gray matter volume. So the nice thing is that there are objective correlates to what the people are telling us. This isn't just quote unquote all in their head. This actually is really happening to them. And then evidence for impairment of the blood-brain barrier. Okay. This is going to be a topic that we're going to talk quite a bit about when we talk about therapeutics, is a lot of individuals develop vagal nerve dysfunction, neural dysfunction. And stuff that we can objectively see. So one is some ultrasound studies showing thickening and hyperechogenic vagal nerves. The vagal nerve is actually swollen weeks, months after the acute infection. Reduced intestinal peristalsis, like people just the bloating and some of the gastrointestinal symptoms that we're seeing, you actually can get in, reduced intestinal peristalsis. Tachycardia, something that if you've taken care of people with COVID, you're probably seeing quite a bit of. And not only just the tachycardia, just sitting there with tachycardia, but when they exert themselves, a minute, 2 minute, really takes quite a while for that heart rate to come back down. And that vagal role is really not sort of doing as well as it did before. Orthostatic hypotension, dizziness, dysphonia, dysphagia. So a lot of autonomic symptoms might be what gets presented. And mitochondrial dysfunction, yeah, it's actually some objective evidence that this isn't just a theory, but in certain individuals is present. Evidence for downregulation of core mitochondrial genes. Actually myopathy and focal necrosis triggered by this post-exertional malaise. And we're going to talk a little bit about that, right? That it's sort of that ethic of, oh, if you're weak and you're tired, you just have to kind of push through it. And then unfortunately, some evidence that pushing through it and triggering this post-exertional malaise because of mitochondrial dysfunction, probably that seems like the biggest connection here. You may actually be triggering focal necrosis. So you may actually be harming your patients by sort of telling them to buck up and push through. And then, I think we've all seen this is, we had a lot of patients early on who spent months in the ICU on ventilators. They ended up with pulmonary damage. Uh, Actually, some people even ended up requiring lung transplants. It was pretty horrible. Cardiac damage. And, if you had hypoxic damage to your brain, that doesn't just bounce right back. All right. So this is a list, and I think everyone will get a copy of the slides to go through. But there's actually sort of a panel of tests that you can send off on your patients. Part of this is trying to maybe understand the drivers, but part of it too is a lot of these patients, by the time they come, I'm going to say us, because everyone who's listening to this is basically a provider who really wants to help these folks, right? Otherwise, you wouldn't be wasting your time. You're not here just for my cool bow ties, right? Um, and so there's a number of things that you can test for. And then even if it's understanding, even if it's just being able to say to patients, hey, I'm seeing a biochemical abnormal profile, which actually is consistent with an individual that has passed. This is sort of helping to reinforce that you're not making this stuff up. And then we can really focus on what can we do. So not only are these abnormal, but they may be tied in with the pathology. So we often see markedly elevated EBV, CMV, and VZV serologies. And the whole idea is these groups of viruses can actually reactivate during acute disease. And that reactivation may actually be part of the pathology that we're seeing. So a patient EBV, for instance, they might come in, they might get sick. Severe cases, maybe 20%, you can actually pick up the EBV with a nucleic acid amplification test during the acute phase. And then what ends up happening, because you get these reactivations, the serology levels, the IgG levels go sky high, evidence, after the fact that that happened during the acute period. There are also couple studies, and some of these studies came out of Yale, some came out of Pittsburgh, some came out of Mount Sinai or collaborations, is this interesting phenomenon where you have a low AM serum cortisol without a compensatory ACTH elevation. So it's sort of a PASC issue with your cortisol, with your adrenal function. You might see anemia, abnormal serum iron. You might see ongoing lymphopenia or thrombocytopenia, diminished serum serotonin, right? So this was initially described by the Pittsburgh group and then was actually replicated in a Cork Irish group, interesting enough. And these are individuals where you measure their serum serotonin and it's single digits, right, as opposed to what we'd normally expect. Psychiatrists hate this because they tell us this is meaningless, but it is actually something characteristic of this population. And it does seem to correlate with some of the therapies that we might try. So we'll circle back to that in therapies. Diminished serum serotonin, abnormal coagulation studies, low albumin levels, elevated serum aminotransferases, AST, ALT. I know people call those liver function tests. The wards at Columbia right now, I'm like, they still let you call those liver function tests because they're really liver damage tests. Yeah, elevated liver damage tests, abnormal lactate dehydratase levels. Sometimes we see elevated CRP or ESR, bilirubin, lipase levels. And then these are all, you could just order these, right? You could have a panel, click the boxes, send these out. Serotonin, I know in a lot of our areas, you wait about 3 weeks before it comes back. But then there's a number of others that are available in research centers. So elevated levels of neurofilament light chain, right? So this is along the lines of the ongoing activation of the brain, basically, the glia cells, et cetera. And then, if you have access to looking at the microbiome, you actually see the depletion of the commensal bacteria, an increased abundance of some of those bad players, abnormal activation of CMV specific CD8 positive cells. And then we talked about the viral antigen persistence, whether that's protein or whether that's RNA. And I'll leave a link because this is a paper that I published where, each one of these I then reference, like, what was the study? Why are we saying this? Where did we see this? Who saw this? So those were the biochemical abnormalities. There's also physiological abnormalities. So when someone comes in and you're considering the diagnosis, not only is there a panel of blood tests that you can send off, but there's also a number of physiological tests you can do. And again, that same paper is going to walk you through how to do each one of these tests, either in the office or if you're doing this via telehealth, how to walk the patient through it. Some of them you may have to have referred to someone who can do it for you, but one really easy, the abnormal NASA lean test. Maybe everyone's watching the Artemis, so we're all excited about NASA. And yes, the same NASA, um, where the person basically is relaxing so that the muscles are not helping to maintain the blood pressure and the heart rate. Certain criteria for people with PASC where they have issues with heart rate really goes up or blood pressure goes down. Pseudomotor assessment, where they basically are having issues sweating, right? So this is the issue with the autonomic uh, nervous system. Exaggerated orthostatic blood pressure response, the heads-up tilt table test, which probably start with the NASA because the tilt table might be a little too much for some folks. And some folks, it might actually trigger a post-exertional malaise. And now they're not doing well for weeks. And they're not happy that you confirmed it when maybe the NASA lean test was enough. Doing a Holter, looking at this heart rate variability. As I mentioned, a lot of people get tachycardia and then this failure to recover. The heart rate goes up and it stays up. And it stays up. This is that abnormal heart rate recovery 1 minute post exertion. So they exert themselves and then the heart rate should come down. But instead of just that little post exertional rise and then a nice drop, it rises and it stays up. And then more sophisticated, we might do cardiopulmonary exercise testing that can be abnormal. We might just do simple ECG monitoring where we pick up rhythm abnormalities. And then abnormal pulmonary function testing, particularly if you include the DLCO testing. So really, if you're going to do it, do the full. All right, so now we've talked about which baseline tests you might want to do as far as biochemical blood work, which baseline physiological tests. And really you're thinking, I'm already doing quite a bit to sort of get these people characterized. Well, what was the point? The point is not only to give people some validation, not only maybe to try to understand what's driving the post-acute sequelae in your patient, but also trying to understand what phenotype they might fit into at this moment. Because that's going to tie in, as you'll see shortly, into different things you might want to try. And I say at this moment because some of the studies have shown that a person with a particular phenotype is not static. They might have one phenotype this time, and in 3 to 6 months later, there may be a shift. So you may have to sort of chase your tail. So there is the classic long COVID, probably the first that was described by some of the support groups, the ME/CFS phenotype, right? So the myalgic encephalitis chronic fatigue syndrome phenotype. Unclear, right? Is this really the phenotype or is this just ME/CFS triggered by SARS-CoV-2? And that's that fatigue, post-exertional malaise, really meeting the ME/CFS criteria. There's the cardiovascular phenotype. People are going to have overlap here, but these might be people with the tachycardia, the arrhythmia issues, the orthostatic hypotension. There could be people, their main issue is respiratory. It's just having mainly trouble breathing, shortness of breath. I had a triathlete, couldn't even make it up a flight of stairs, going from being a triathlete to I can't even go upstairs. There's an endocrine phenotype. You could think some of that might be the cortisol and some other issues. The neurological phenotype, where the main complaints are cognitive, brain fog. There's a GI phenotype. People have ongoing diarrhea. They have bloating. They have, issues with things just not moving through, the decreased peristalsis. There's even a reproductive phenotype. And then maybe the one that will be sort of easier for us to think about how to treat, but this allergic immune activation phenotype. You can already sort of think about what medicines might be helpful in that subgroup. Okay, so first, prevention. How do you not get long COVID? You don't get COVID, right? If you don't get acute COVID, you can't get long COVID. And you still can make smart decisions to avoid getting infection. So, it's like the weather. You see that, hey, it's raining outside. You think about how not to get wet. It's the peak of the COVID season, and it's two COVID seasons now, right? It's every sort of December through March, and then every sort of starts in July and then goes into September, right? So we have these two peaks. So during a peak, there's a lot of COVID going on. Might not be the time to hold that business get together and get everyone in a crowded, poorly ventilated room. Or if they're going to do that, you don't have to go. You might call out pre-sick. I like that. I'm going to coin that pre-sick. I'm calling out because I don't want to be sick in 4 days. Um, Vaccinate, and masks and ventilation and everything else. Vaccination. Not only can vaccination reduce your chance of getting acute COVID, but consistently, vaccination for the 6 months after that booster reduces your risk of getting long COVID. So sort of arguing for that every 6 months. Unfortunately, that, I wish the body and the world knew that, we live in a 12-month year, but that's the science. Nirmatrelvir, ritonavir, maybe. And I'm just going to say maybe, conflicting there. Convalescent plasma, maybe. Corticosteroids, not during the first week. That may increase your risk, maybe during the second week in the right patient at the right time. You'll notice what's not on here is the monoclonal antibodies during the acute phase. I was the principal investigator on the largest monoclonal trial. And when we looked through the data, unfortunately, we did not see that we were really having a significant effect on preventing long COVID. So published study, but unfortunately not what we were hoping to see. All right. So now the patient is in front of you and they've actually gotten long COVID, right? So we didn't prevent it. They've got long COVID. They're coming to see us. We've done our blood work. We've done our physiological testing. We've taken that careful history to get a sense of how is this impacting their life? How are they doing before? How are they doing now? And to sort of think about what are the evidence-based interventions that we might try. So let's go through these one at a time. So what might we consider for everybody? So can we use vaccine as a therapy? Is there therapeutic vaccination to treat long COVID? Now, one of the first studies that I was involved with was the one out of Yale, where basically we vaccinated individuals that had long COVID. It actually took quite a while to identify these folks. And why was that? Because I think there was already out there this idea that most people with long COVID got better after vaccine. So I'll tell you the story. So here it was. It was December of 2020, right? The vaccines are just rolling out. A lot of the folks that I'm taking care of with long COVID are healthcare workers. So they're going to be in that first opportunity. Already at this point was taking care of hundreds of folks with long COVID. I would sort of do this thing where I'd be in the hospital all day, and then starting at 5 o'clock till like 11 midnight, I would be seeing like long COVID folks via telehealth, like 5 days a week. So we had this discussion. Certain people were just really, really struggling and desperate, and certain people felt like they were a little bit better. And there was sort of this, and it probably came down to their personality. Certain people said, I want to try it. And certain people said, well, I'm going to do it just because I don't want to get COVID again. And so, I'm not even thinking about how this might impact what I'm going through. But boy, can you imagine if I get another, infection without protection? And I made a point. Pfizer was the first one that a lot of the healthcare workers in our area were getting, saying, okay, you're going to get your first shot. Before you get that second shot 3 weeks later, let's check in. And so we would check in, and probably about a third of the folks said, I actually feel better after that first shot. And then after the second shot, we were up to about 50-60% of people actually feeling better after the vaccine. But what's the other side of that? What about the other 40%? That was sort of broken down into some people just feel exactly the same. And there was about 10% that actually said, I feel worse. That really set me back getting that vaccine. And the Yale study actually showed pretty similar numbers. About 60% of people get better. Some people just no change. And then there is a minority of people that actually feel worse. So vaccination after infection, people with long COVID, it's a discussion to have. And part of it is up to the person. Some people say, you know what, I've made certain amount of improvement. I'm just going to do my best not to get infected again. I don't want to take the risk. But a lot of people, and hey, the odds are in your favor. It can end up with a reduction in symptoms, increased well-being. And actually, what we saw in the study is you can actually achieve downregulation of systemic markers of inflammation in that 60%. We're trying to sort of figure out how to know ahead of time who would benefit and not. So I think we still could use some work there. Okay. A big thing that a lot of people with acute COVID would have and then continue to have is ongoing sleep disturbances. Um, and I remember early on, like, not a big fan of using benzos and other things, sleep aids that people might get, addicted to or habit forming. So it seemed to be pretty innocuous to use melatonin. And people were actually saying, hey, this really seems to be making a difference. And I just thought pretty benignly, maybe there's a placebo effect. Maybe it's just, melatonin's helping them sleep a little bit better. But then the first study came out showing that actually melatonin at the right dose, this is important, was not only helping people sleep better, but was actually reducing ongoing inflammation. And that's that right about this 5 milligrams, sort of a 3 to 7 milligram zone. You go up to 10 milligrams, you may actually see the inflammatory markers start to go up. So sort of be careful that you don't overdo it. Too much of a good thing is not a good thing. So melatonin is one of the things to be thinking about, particularly in those patients with sleep disturbances. Actually, I have to say, it seemed like in our area, a lot of people were just adding melatonin in for that ongoing inflammation targeting. So discussion about vaccination, everyone gets their dose, their 5 milligrams of melatonin. Now came like the next sort of exciting study. And initially, it was a group, gastroenterologists, thinking that, maybe if they use this bifidobacterium containing probiotics, that might help with GI symptoms. They did kind of a pilot study. They presented an abstract. What they actually found was that the biggest thing is people were saying, you know what, my fatigue is better, my memory loss is better, I can concentrate. Yeah, maybe it's helping a little with the GI, but it's mainly helping my cognitive. And then there was a bigger study out of Hong Kong. And so, yeah, a chunk of people using bifidobacteria containing probiotics, and the paper talks about what doses you might want to target with this, pretty high doses actually, can actually, in a chunk of people, help with cognitive and brain fog. So sort of trying to restore, but not just any probiotic. It was really specifically restoring the bifidobacterium, which makes sense because in the early studies, that's what we were seeing was depleted. This is really important. Anyone who takes care of folks with post-acute COVID should be familiar with the concept and the risks of post-exertional malaise. And this originally was something that we should have learned from the ME/CFS literature, is that if you push people into post-exertional malaise, if you're not careful and cautious with exercise adoption, you can actually end up harming people. And there was a study where they actually did biopsies of people that got post-exertional malaise, and you saw actually muscle necrosis. So deconditioning is bad, right? Just laying there and not moving, that's not great. We are trying to get people active. We don't want the harms of deconditioning, but you want to be careful. You don't want the harms of pushing people into post-exertional malaise, triggering more inflammation, actually damaging whatever muscle they have left. Now, big thing, people who have decreased vagal tone. And these people you're going to pick up, you're basically going to see the autonomic dysfunction. You're going to see issues with blood pressure, heart rate variability. They might be anxious. I call this Navy SEALs breathing. Maybe it's yoga or other types of breathing, but active cycle of breathing techniques. So things like the box breathing, where you're breathing in slowly, pause, breathing out slowly, and pause, sort of thinking of a box. It does not need to be 4 seconds at each corner of the box. People start getting more anxious because they feel like they're suffocating. The whole idea here is to start promoting that vagal tone. If I can get people to start with a few minutes before they go to bed, ideally, if we can get this up to 15 minutes a day. This is something they actually do in the Navy SEALs training to augment that vagal tone. So when you take these poor kids and put them in these stressful circumstances, that end up tachycardic and panicking. Some folks who have more significant issues, there may be stuff beyond just the active cycle of breathing techniques, the box breathing. There may actually be vagal stimulators, and those are being trialed. There's even some trials in some surgical approaches here to try to help with the augmentation. Sometimes we're even using the cold water in the face. Apparently someone out there has some kind of a device with a snorkel where you put your face in this cold water, but you can still breathe. So now getting into things where there's, I'll say less evidence, but some evidence. So some patients with impacts on working memory, executive function, the NAC is something, maybe something with maybe a little more evidence now. And there was a really nice recent study that we covered on This Week in Virology, where I try to keep people updated on the latest research on this. Certain SSRIs, one of the things which is interesting in the folks that have that very low serotonin, I liken this to try to going sailing when there's really not much of a breeze. You put up this huge sail, but remember the serotonin is like 4 or 5. So some folks actually require higher doses of the SSRIs than we're used to. People with the immune or allergy phenotype, people getting rashes and hives and other symptoms, the antihistamines, right? I mean, that's just sort of a no-brainer, and there's evidence that it works. Now, I wonder how much is this placebo, but we certainly have folks with olfactory dysfunction and dysgeusia, right? They just don't taste right, metallic, other stuff. Limited evidence, but potentially using the topical nasal steroids. But I think a big thing, and this is important, and I think a lot of people on this listening will will resonate with it. There's a lot of trials out there. We're trying to learn more. This is not something that, despite some of the funding challenges we're having, that we're giving up on. So there really are a lot of trials out there where we're trying to learn more. So just to run through, consider for all patients vaccination after infection, patients with sleep disturbances, ongoing inflammation. So maybe something you can think just across the board is something easy and relatively safe to try, melatonin. Bifidobacterium containing probiotics. It's like 10 million, forming units, twice a day. So pretty high doses here. Remember, post-exertional malaise, let's help our patients not harm them. Deconditioning is bad, but pushing them too hard can be bad as well. Think about things you can do to help augment vagal tone. And then there's a number of these other therapies. So NAC, SSRIs, and some of the others. Sometimes when the serotonins are super low, you're not going to use an SSRI. You might want to go to one of the other, maybe a Wellbutrin or Cymbalta or some of the other therapies. Antihistamines, maybe topical steroids, and enrollment in a trial. So, okay, remember, post-acute sequelae, it is actually a defined syndrome. There's a diagnosis code. You can make that diagnosis. Now, talk to your patients, because some individuals will actually meet criteria for ME/CFS. That is a separate diagnosis code. Your patient might be excited to get that diagnosis code. They might be upset. So have a little bit of a discussion about, whether or not that's going to help them or hurt them to have. And then remember, this is a real thing. There are a number of recognized biochemical and physiological abnormalities associated with PASC, and there actually are things we can do to help. So don't forget to be a doctor. Listen to the patients, validate their experience, and really just going through with them and sort of, having that dialogue, like, oh my gosh, I'm not the only one going through this. Make that diagnosis, accurately code for it. Go ahead and manage the comorbidities. Sometimes it takes a village, takes referrals. So find those doctors who actually are going to treat these patients, because there are some folks out there, we probably know who they are, who really are just don't want to take care of folks with long COVID. That's not the person to refer your patient to. And then share both the uncertainties around the prognosis and realistic goals for recovery. A lot of folks get better. That is the natural history for a lot of folks, but some folks continue to struggle, and sort of letting them know that commitment that if they're struggling, we're going to keep struggling with them. And I'll close it for questions.
All right. Thank you, Dr. Griffin. I'll give it a minute. Oh, I see Dr. Chow has
Yeah. So thank you all for thanks Dr. Griffin for a splendid talk. For those who don't know, Dr. Griffin has a spectacular a podcast that's called Microbe TV, and he goes over various infectious disease um, um, sessions, of curiosities, as well as um, different updates, and it's ongoing. So and you could view his whole library at your leisure. So thank you again. So one of the questions I have is, if someone doesn't have the biomarkers that you listed, are they, how, I guess it's oftentimes the test will try to help prove or show that you have long COVID, but does a negative test also show that you don't have long COVID? Or what do you say about people who have symptoms and that have temporarily been consistent with long COVID, but then don't have any of the positive biomarkers?
Yeah, so it's not required. It's
Mhm.
a clinical diagnosis. The person had COVID, they have ongoing or new symptoms, we'll say 90 days, use the real, like if really entrenched. Yeah, the biochemical, the physiologic, everything can be normal. It doesn't, you do not need to have those. If you have those, that can be helpful, it can be validating. But if you don't have them, that does not mean you don't have long COVID.
In the oftentimes we do the CMV, EBV titers, and serology testing oftentimes comes back positive, suggestive of higher amounts of the herpes virus viridae serology. So do you ever treat those patients with Valtrex? I know some of the clinicians have used those before, and what's your take on that?
Yeah, so I mean, I have actually.
Yeah.
There are some trials where they're trying to look at that and different doses. And some patients actually, with long COVID will be getting recurrent cold sores. They'll actually be getting
Yeah.
sort of evidence of some of these herpes viridae reactivations. Those I definitely, and sometimes I even end up having to go to higher doses than your standard 500. It might be 1,000 of the Valtrex. Um, and so, yeah, so, we're trying to figure it out. And there are some ongoing trials, and I certainly have done it. And whether it's, causal or coincidental, the benefits, so.
Do you also give them Celebrex with that, or
So I
I know that
don't.
they're good. Oh, okay.
Yeah, I
You
don't, but I
just
know
give
that's
it.
something. Yeah.
Oh. And then, do you think that yeah, oftentimes, given all these different symptoms, do you think that heterogeneity with all the different systems, do you think that there's a different mechanism of, because you nicely point out you have like a GI one. Do you think that there are multiple mechanisms to long COVID?
I do. I think with the phenotypes, I don't think everyone gets long COVID the same way. I think that there's the different phenotypes are driven probably by different mechanisms. So like there's certain people that develop almost like a mast cell activation
Yeah.
syndrome, and some of the stuff isn't exactly right, but it's similar to what we see in people with MCAS. And I think that's different than some of the people who seem like to have a very clear vagal dysfunction, or people that have
Yeah.
other, like maybe they had the cognitive issue. We give them, the bifidobacteria, and now they feel great. And I'm saying it probably is a different character than some of the other ones.
In the viral antigen testing that you do, can you explain that? Which one is it? The nasopharyngeal one, or
So the
blood, or
viral, yeah, the viral antigen, that's going to be in a research
yeah.
study. So you're not necessarily going to be,
Okay.
looking and doing more PCRs up the nose. But, some of the early studies, they would go and it'd be 6 months later, you do an EGD, you do biopsy, and you're still able to, PCR
Mhm.
or stain and see remnant RNA, remnant protein. Really challenging, like this whole idea that we were all taught that, like, I mean, I work in the lab. When I would work
Yeah.
on RNA, I would like close off my whole bay. No one can
Yeah.
visit. I'd wear a mask. It was like, the RNA was going to like disappear if I had a bad thought, right? And now, oh my gosh, it's 6 months later, and the RNA, it's still there.
Yeah. Yeah, we had our own study where we didn't do any nasopharyngeal biopsies or tongue biopsies or the colonoscopies, but we have done blood work on looking and trying to recover blood, but from the virus in the blood system, and we weren't able to find any detection of the virus in blood. So we think that it's most likely tissue specific. I think other groups have also said that they weren't able to also recover from blood samples.
Yep,
So
yep, that's consistent. Yeah.
yeah. And then I'm sorry for dominating some of the questions, but what are your opinions of you see Rinvoq, pirfenidone, IG, IVIG? We've had other end of speakers kind of talk about some
Mhm.
of those things, and what's your take on some of those other therapies right now?
Yeah, so I shared on
Yeah.
the last
Yeah.
This Week in Virology
Yeah.
podcast about it was an N of one, so it was an experienced person got
Mhm.
IVIG and they got better and they hadn't been doing better,
Mhm.
and so it was sort of begging the question of, oh, they're going along, was it really they just happened to get better when they got their IVIG treatment? And that isn't the only case report out there. There's a few others, so there
Yeah.
are some trials. One of the challenge, right, is IVIG is it's not inexpensive. So it's
Yeah.
sort of a big lift until we actually get, the evidence-based indication.
Yeah, I think the NIH Recover, which we were part of, that will hopefully definitively state if the IVIG works or not. We were part of also in the same trial. We were part of the Avaverdine, and that one unfortunately didn't show any benefit so far. Perhaps maybe in looking at the other groups, specific groups within, but overall the whole trial was not suggestive that Avaverdine helped our patients. Unfortunately, yeah. It did treat the POTS symptoms, but it didn't help the symptoms of the long COVID, unfortunately. Yeah. Melissa, do you
All right, let's
go ahead?
see. Let's give it a second. Does anybody else have any questions before we wrap up today? See, I'm not seeing any hands or anything in the chat, so we'll go ahead and end there. So thank you, Dr. Griffin, for joining us today. And I just want to let everybody know the slides for today are already up on the iEcho website. And here in the next 48 hours, the video will also be up there too. And then if you have somebody that wants to watch this, but also still wants to earn the CME, this presentation will be available on the Hawaii Pacific Health website as well. So feel free to go back to any of those places if you want to re-reference this. And then if you're interested, our next session is on May 12th. It's going to be pediatric long COVID, what every clinician needs to know. And that's actually going to be part of a two-part series. So it's going to be the basics the first section and then dive into a little bit more specific stuff in the second session. So that's it for today. Everybody have a great rest of your day.